Hello, I'm Dr. Shakthesh. If you're new to this channel, I'm an ENT and sleep apnea surgeon. I run the Hopkins ENT and Nose Snore Clinic in Chennai, India. So I post a lot of medical information videos both for medical professionals and as well as patients. And I'm also a travel and drone enthusiast. I post videos of that as well. So if you're interested in my videos, please do consider subscribing to my channel and do not forget to press that bell icon so that you can get notified every time I post a new video. So having said that, let's move on to today's topic, which is drug-induced sleep endoscopy. At the outset, let me tell you that this video is for medical professionals. If you're looking for videos for medical information from patient's perspective, I suggest that you look in my playlist. I am sure that you will find the content that you're looking for, and in case if you are not finding the content that you're looking for, please let me know in the comment section. I will try to make a video on that topic as well. So let's get started. As you're all aware, obstructive sleep apnea is considered a modern day silent epidemic with a lot of previously unknown morbidities being associated with it. But thankfully, the awareness regarding the condition is on the rise among both medical professionals and as well as patients. So a lot of patients are seeking treatment for obstructive sleep apnea these days. But a proper and accurate diagnosis of obstructive sleep apnea is of paramount importance in deciding the successful treatment of the patient. This is because an inadequate and inaccurate diagnosis of obstructive sleep apnea can result in frustrating and sometimes catastrophic consequences. So what are all the diagnostic requirements in an obstructive sleep apnea patient? So we need to have clear-cut information regarding two things. Number one, we need to know what is the severity of the condition in that particular patient, for which we do polysomnography or sleep study, which is beyond the scope of this discussion. So we are going to concern ourselves with the second part of the evaluation, which is the upper airway evaluation. As you know, the upper airway is considered the center of the pathophysiology of obstructive sleep apnea. So a proper assessment of obstructive sleep apnea is the key component in deciding the management of obstructive sleep apnea patient. So if you take the upper airway, the dynamics of the upper airway are grossly different from the awake and the sleep state. So Muller's maneuver and flexible endoscopy done during the awake state may not be accurately representative of what is happening to the patient while the patient is sleeping. So we needed a proper upper airway evaluation while the patient is sleeping. So for this purposes, two technologies were developed. Both involved putting the patient to sleep by administering some drugs, and on one side it was a radiological evaluation, either CT or dynamic MRI was done. On the other side, a drug-induced sleep endoscopy was done using flexible scope. So we are going to concern ourselves with the drug-induced sleep endoscopy. And why? Because today drug-induced sleep endoscopy is accepted as the norm for evaluation of upper airway in an obstructive sleep apnea patient. This is because ultimately the surgeon is going to decide upon the treatment. So it is easier and convenient for the surgeon to do the drug-induced sleep endoscopy himself, assess the patient properly, and then decide upon the treatment. So we are going to discuss about how to do drug-induced endoscopy, what are the drugs preferred, what are all the precautions to be taken, what are all the complications to be expected, and how to assess the patient according to the Vogt classification and the diagnostic implication of each findings that we note according to the Vogt classification. So something about the history of drug-induced sleep endoscopy. This technique was first presented by Croft and Pringle way back in 1991 in the Clinical Otolaryngology and Allied Sciences, and then in 2011 Kesirian, Hohenhorst and De Vries presented a proper way to assess a patient's upper airway using what is known as Vogt classification. So this is about the history. So we'll start about how to do the procedure. So typically A patient would have done the polysomnography prior to doing a drug-induced sleep endoscopy, so that we have an idea about how severe the patient's condition is. So that is very important, because we need to know how severe the patient is. That's going to decide how much of drug you're going to use, because if the patient is having a very severe sleep apnea, you have to be very cautious about the administration of the drugs. We need to adjust the drug, because a severe sleep apnea patient will just like that fall asleep. So patient gets admitted with a pre-operative or pre-procedure fasting for at least 6 hours before the procedure, and this procedure is done in an OT setup for safety reasons. Though largely drug induced sleep endoscopy is a very safe procedure, no complications can be expected on a routine basis, but it's a good idea to do it in an operating theater setup. This is because obstructive sleep apnea patients have a very unstable airway. So anytime some patients may go in for airway related issues, which needs to be supported promptly by the anesthetist. So it is better to do it in a place where all those facilities are available. So we do it in an operating theater setup. So the drugs, what drugs we use? So there are two drugs which are preferred. One is propofol, as we all, which is the anesthetic agent, and the another one is the dexmedetomidine. That's another drug that we use. So as of propofol, the propofol is an anesthetic agent. It induces sleep and sedation in a very quick manner, and which is both advantageous and disadvantage, because the onset of sleep is almost instantaneous with propofol, but it can sometimes take the patient too deep, and that can result in a that's not ideal for evaluation of a sleep patient, because we want the patient in a natural sleep like level. So in that aspect, sometimes propofol, if you are not careful about the dose, it can lead on to a deep sedation, and propofol can sometimes cause respiratory depression, which is an issue. On the other hand, dexmedetomidine is a highly selective alpha-2 adrenergic agonist. So it induces a natural sleep-like state in a patient, and so the patient is never like respiratory reflexes are not compromised. The patient almost, he feels like the patient is naturally sleeping. The only issue with this dexmed is that sometimes in certain patients it can result in hypotension. It can reduce the blood pressure. That's the only issue with dexmedetomidine. Otherwise, it's a safe and fantastic drug. And nowadays, our drug of choice for drug-induced sleep endoscopy would be dexmedetomidine only. So as of the dosage, propofol we give 0.7 milligram per kilogram body weight as a bolus, followed by 0.5 milligram continuous infusion as maintenance. As of dexmed, we use 1 microgram per kilogram body weight as a bolus over a period of 10 minutes, then followed by 0.3 microgram per kilogram body weight as a continuous infusion for maintenance. So then comes the position of surgeon. So there are two positions that are used by surgeons. One is standing at the head end of the patient, and the another is standing at the side of the patient. So both are equally good, and I personally prefer standing on the side of the patient. That's only a matter of personal preference. And as far as the patient's post-procedure care, the patient generally stays in the hospital for 3 to 4 hours, and after he feels comfortable and awake, we generally discharge the patient and ask them to come back some 2 or 3 days for discussion of the findings that we made. So as for the complications, as I said before, it's extremely rare, because we are going to have the anesthetist. The anesthetist is going to know about the severity of the condition, so he's going to take proper precautions and adjustments of dose depending upon the severity of the condition. So the complications are quite rare. Rarely you can have some patients who will require assisted ventilation for some time. Other than that, it's quite a safe procedure to do if you take all the right precautions. So that's about the procedure. Next, we are going to see about how to do the proper assessment of the patient as per the VOTE classification. So the VOTE classification, the VOTE actually stands for Velum, Oropharynx, tongue base and epiglottis. But in addition, nowadays we use the nasal cavities and as well as the larynx in the assessment. So you're going to start with, you're going to properly evaluate both the nasal cavities, then you proceed on to the velum, then you examine the oropharynx, then you come to the tongue base, then you see the epiglottis, and finally you look at the larynx and hypopharynx as well. So this is the proper way of examining, and in each level apart from the nasal cavity, it is suggested that you spend at least 2 apneic episodes at one level, so that we know what is happening in that level during at least 2 apneic episodes. So coming to the word classification assessment at the level of velopharynx. So we need to look into two things: the severity of the collapse and the type of collapse. As far as the severity of collapse, you have complete patent, you have partial obstruction and complete obstruction. You call it patent when the inspiratory dimension at velum is more than 70% of the dimension during expiration phase. That is completely patent. And if the inspiratory diameter is less than 70% of that during the expiration, we call that partial obstruction. And if there is a complete obstruction at the level during inspiration, it is called as a complete blockage. And as far as the type, in velum you have 3 types. One is the anteroposterior, number 2 is the lateral collapse, and number 3 you have concentric collapse. So we have 3 videos here, all taken at the level of the velopharynx. The first one is an anteroposterior collapse. So we call anteroposterior if the collapse happening at the anteroposterior dimension is much more compared to the lateral collapse, because there can be little bit of lateral collapse, but we don't term them as lateral collapse or combined collapse as long as the anteroposterior collapse is significant. So this is an anteroposterior collapse, and also note that it is partial, as because you are able to see some amount of lumen at any point of time. This is a partial collapse happening at the anteroposterior level. So, and the second video is a concentric collapse happening at the velopharynx level. So as you can see, the collapse is equal in both the lateral and as well as the anteroposterior dimensions, and it is also a complete collapse as the space completely collapses during inspiration. So the third one is a lateral pharyngeal collapse happening at the level of the velopharynx. As you can see, the patient is having a very thick salpingopharyngeal fold which is collapsing on the lateral dimension, causing a lateral collapse at the level of the velopharynx. So what are all the diagnostic implications of all these variations? If it's going to be a pure anteroposterior collapse, so whatever procedure you're planning for anterior posterior collapse would help for the patient. In case of patients who are having concentric collapse, just procedures oriented towards the anteroposterior is not going to be helping. So we need to do a procedure which can expand in the lateral dimension as well. And as far as the third patient who is having a thick lateral pharyngeal bands, he will require some procedure to stiffen and shrink the salpingopharyngeal fold, like a coblation stiffening of the lateral pharyngeal fold at that level. So that is the diagnostic implication of these 5. So next we move on to word classification at the level of oropharynx. So once again, similar to oropharynx, we have the same severity classification of patent, partial obstruction and complete obstruction, and also the type is also similar here. We have circumferential collapse, we have anteroposterior collapse, and as well as lateral collapse. So we'll have, similarly we have 3 videos to show you each of these collapses. So the first one is an anteroposterior collapse. As you can see, the lateral collapse is very minimal compared to the gross anteroposterior collapse that you are having here. Then for the second video, you have a typical lateral wall collapse. You can see here there is practically no anteroposterior collapse. The collapse is mainly happening in the lateral pharyngeal wall, in the lateral dimension. So this is a classic lateral complete collapse at the level of the oropharynx. So, and the third video is a concentric collapse. So as you can see, both the anteroposterior and the lateral collapse are more or less equal, resulting in a purse string kind of appearance. So this is concentric collapse happening at the level of oropharynx. So once again, what are all the diagnostic implications? So if it is an anteroposterior collapse, a palatal procedure like a modified Friedman's procedure is going to help the patient. If it is only a anteroposterior collapse, and if the anteroposterior collapse is only partial and the patient is not having a very severe sleep apnea, you can consider conservative procedures like anterior palatoplasty for the patient or palatal stiffening. So that is for anteroposterior collapse at the palate level. And the next, for a lateral pharyngeal collapse, which is exclusively lateral pharyngeal wall collapsing, we have to consider a procedure like expansion sphincteroplasty for that patient, because anteroposterior collapse procedure is not going to help the patient with lateral collapse. And for a patient who is having a concentric collapse, you would need to do a much more aggressive procedure like a ZTF palatopharyngoplasty, because both an exclusive anteroposterior procedure or a lateral procedure is not going to be enough for this concentric patients, as they tend to do bad. So we have to do a more aggressive procedures to help these patients. So for the concentric collapse, a ZTF palatopharyngoplasty would be an ideal procedure. So next we move on to word classification at the level of base of tongue. Here things get different. You have grades. So grade 1 is where you are able to visualize the valvula completely. In grade 2, you are able to visualize the valvula but only partially. In grade 3 base of tongue, the base of tongue is actually touching the epiglottis. And grade 4, the tongue actually pushes the epiglottis posteriorly. So that is grade 4. So strictly speaking, grade 3 and grade 4 are considered base of tongue collapse. So grade 1 and grade 2 don't matter much. So we are going to have videos for those. So the first one, as you can see, is a grade 1 base of tongue. So you are able to, while the collapse is happening, you are able to completely visualize the valvula here. So this kind of situation is called as grade 1 base of tongue. So in this next video, what you are seeing is a grade 2. So where we are able to visualize the valvula but not completely. So as and when the apnea and the collapse happens, the tongue is coming and filling the valvula partially. So that is grade 2 base of tongue. And the third video is a grade 3 base of tongue, where the base of tongue is actually collapsing and touching the epiglottis. So this is grade 3. So diagnostic implications: grade 1 does not require any treatment. Grade 2, maybe you can think of doing a stiffening procedure like coagulation channeling of the tongue base. For grade 3 and grade 4, we need to consider base of tongue reduction procedure or base of tongue repositioning procedure. So next we move on to the put assessment at the larynx level. So at the larynx level, you mainly look at the epiglottis and as well as the arytenoid and the hypopharynx area. So in epiglottis, you have anteroposterior collapse and an inward collapse of an elongated epiglottis. In an anteroposterior, you have 3 grades. Grade 1 is where you are completely able to visualize the vocal cords at all time. Grade 2 is where the vocal cords are visualized only partially. And in grade 3, the tip of the epiglottis actually touches the posterior pharyngeal wall. So, and infolding of an elongated epiglottis can happen. That is what we refer as an infantile epiglottis, which is collapsing, causing obstructive sleep apnea. And then sometimes you can have arytenoid collapse, arytenoids collapsing inwards and causing obstructive sleep apnea. So we have 3 videos again. So the first video is a grade 1 epiglottis where you are able to visualize the vocal cords completely while the apneic episodes are happening. And then the next video is where you are able to only partially visualize when the apnea is happening, the epiglottis is moving posteriorly, so we are not able to visualize the vocal cords completely. So this is a typical grade 2 epiglottis. And the third video is a beautiful video where this is a grade 3 epiglottis where the epiglottis completely touches the posterior pharyngeal wall and closes like a lid and completely blocking the airway during an apneic episode. So that is grade 3 epiglottis there. And then the fourth video is the elongated infantile type epiglottis. As you can see, the epiglottis is collapsing inwards. It is an elongated infantile epiglottis which is collapsing on the lateral dimension, or it is folding like a door. So this is elongated epiglottis closing on itself. So the diagnostic implication, grade 1 you don't have to do anything. Grade 2 maybe we can consider freshening the edges, that is the mucosal surface of the epiglottis on the pharyngeal side, and inducing an artificial adherence to the base of tongue. You can create raw areas both in the vallicula and as well as the epiglottis, and that can reduce the collapse in grade 2 levels. For grade 3 epiglottis, we need to remove the free edge of the epiglottis so that the collapse is minimized. So these are the various levels of collapse which has to be assessed according to Vogt classification and the diagnostic implications of each finding. So this proper assessment of upper airway during sleep using drug induced sleep endoscopy is going to go a long way in giving the patient a successful and satisfying experience in the obstructive apnea treatment. So I hope that this video would have helped you get an idea about how to do a drug induced sleep endoscopy and how to accurately grade and decide upon the treatment for the patient. So if you have any doubts, queries or corrections, please do let me know in the comment section. I will try to address, correct and rectify those concerns. So thank you very much for your patient listening.